We sort of would look at a patient and say, would we categorize them at the moment they're seeing us, whether this is initial therapy or they're on a therapy and we're looking at adding a second, making it a combination approach. We have to decide in general, are they a more stable pulmonary arterial hypertension patient, or are they really an unstable pulmonary arterial hypertension patient? And a more stable patient has no or really very little evidence of right ventricular failure. So not much in the way of lower extremity edema. They don't have very distended jugular veins. We would say in the WHO schema, they're functional class 1 or 2. On a hallway walk distance in 6 minutes for the 6-minute walk test, they probably walk at or greater than 400 meters. On echocardiography, their right ventricular size tends to be fairly normal with good function. If we do the heart catheterization, we would expect right atrial pressure and cardiac index are normal. And if we were to do blood testing for brain natriuretic peptide, again, that would be near normal or only minimally elevated. Now contrast that with the less stable patient or the unstable patient. This is someone who does have evidence of right ventricular failure. Certainly if someone presented with a swollen abdomen due to ascites, that would be considered a less stable patient. If they're a functional class 4 patient, they're someone who's short of breath at rest and is symptomatic with even basic activities of daily living, that's an unstable patient. In a hallway walk distance, we'd expect that their walk distance is probably less than 300 meters. On imaging, their right ventricular function may be diminished along with an enlarged right ventricle. Right atrial pressure would be high on heart catheterization and cardiac index low. And then finally, if we looked at things like brain natriuretic peptide or perhaps N-terminal, NT-proBNP, those levels may show significant elevations. And so when we characterize them finally as stable or unstable, the stable patients we're going to tend to gravitate more towards an oral therapy and then follow them up in the office maybe every 3 to 6 months. When they're the unstable patient, especially someone that, say, presents in the emergency department or presents to the office the first time in a functional class 4 state, we don't always want to take the time to wait for the onset of action of an oral therapy. We might admit them or very quickly move to a prostacyclin approach, and in many cases that may be an IV or subcutaneous, really a parenteral prostacyclin, and that person's going to follow up much more often in the office, more on a 1 to 3 month basis.